So everyone, please give a big hand to Dr. Anders.
Thank you very much for the nice introduction, Jason. I'm not so good at Chinese, so I'll talk in English tonight, and I'll try to speak very slowly. And if you have any questions on the way, please raise your hand. Don't be shy. I would like you to go away after 3 hours tonight with as much knowledge as possible that I can share with you at least. I don't know how many of you who has heard me before up here, but just to introduce myself, I'm a chiropractor of profession. And in Denmark, chiropractors are part of the medical profession. So we go to medical school for 6 years and specialize in orthopedic departments, rheumatology departments, rehabilitation departments, and radiology departments. And after 6 years, we can go into internship and go to private practice, or we can study on in the hospital setting for another 5 years and stay there and practice together at the specialized hospital departments. So we specialize in musculoskeletal medicine, in manual medicine, but we also do injectional therapy and prescribe medicine if that's necessary. So I have a wide angle within all these kind of treatments here. About 18 years ago, I started working with focused shockwaves. And that was due to I had a lot of sports injuries that did not respond properly to rehabilitation and manual medicine or prescription drugs. And I found out that that new technology at that time could do a great difference. And 18 years ago, we had some other machines, some other devices. And today, I'm here to talk about the Pcl 2, which is our preferred device in the clinic. We have 4 of these at our clinic. And we are 7 physicians and 3 chiropractors working together in private practice. And we not only see spinal problems, but half of our patients are sports injuries. And probably in Europe, like in Asia, it's not only sports elite athletes which come in with sports injuries, it's also normal runners at any age. Badminton players, tennis players, they come with the same injuries. So we have a lot of influx of these patients nowadays. We only have 3 hours together tonight. So this is the program for tonight. How many of you are working with focused shockwave right now? Can I see a hand? Oh, quite a few of you. And how many are working with this device here? A few of you. Okay. So I won't bore you too much about the technology and the evidence about it here, but because I want to go into areas which are not treated so often, but that we treat a lot right now, I'm just going to talk a little about the evidence for sports injuries and what the newest evidence has shown. After that, you can have a little break and a refreshment, and then we'll go into the practical session where I'll try and demonstrate how you can use ultrasound scanning to help you during practice. I'm going to demonstrate some treatments not only for tendinopathies but also for osteoarthritis, meniscus lesions, labrum lesions in the hip that you can also help with these focused shockwave devices here. I'll talk a little bit of theory for each topic, and then I'll try and scan one of you with some problems, and then I'll try and treat them so you can see how I utilize it during practice. So it's going to get very practical for you. And we have a question and answer session at the end, but during the demonstration, feel free to ask any questions if you want to. So the funny thing is that focused shock waves were actually already started up in the 1980s, and they used it to actually treat renal stones, where they used very big machines with a high energy output to actually shatter those renal stones so that they disintegrate. And the reason why they started treating other musculoskeletal problems was that when they treated these patients up through the pelvic rim, they saw from the scatter radiation on the pelvic rim, they saw new cortical bone formation. So at low doses, focused shock waves actually produced new bone cells. And some smart doctors thought, how can we use that for other conditions? And then they started thinking about chronic tendinopathies, which didn't respond to rehab or medicine. And they found out if they gave focused shock waves at lower doses, these cells started responding and healing up again. So take that in mind. So when we go on with this topic here. So a shock wave is a very high-powered pressure wave, which is exceeded in a very short time span. And it consists of this positive phase here and a negative phase. And each phase causes different biological responses in the body. And each device on the market, the other manufacturers, has a different shockwave pattern. Some produce a lot of energy, some produce lower energy, some produce a larger shockwave wave than the other ones. So each device has different abilities. And the reason why we use this right now is that it has a very good ability to modulate pain. So we don't only regenerate tissues, we can also pain modulate things. So, not to confuse you with it, that shock waves have a very large high energy compared to radial pressure waves or shock waves. They are not the same thing. Radial pressure waves, we use that at the clinic too for muscular work, but they do not produce any biological changes. Radial pressure waves, they can modulate pain in some instances, but they cannot regenerate tissues. So these are the devices that I'm going to talk about here. This here you can use to muscular therapy with great results. But if you want to regenerate tissues, heal up tissues which are pathologic, and if you want to pain modulate very heavily, you have to use these devices here. To start out with, shockwave therapy started out with one technology, and it was this electrohydraulic principle, where they produced the shock waves from a spark plug down here with a lot of energy, a lot of voltage, and that produced this cigar-shaped treatment zone we have here. Later on came the electromagnetic principle, which Storz and Dornier use right now, a more modern one. And the latest one is this piezoelectrical principle, which the PizzaWave 2 uses. It consists of a lot of ceramic plates, and when we put a high voltage to them, they contract and expand, and when we converge them, they make the same shockwave therapy zone like here. So there's been done a lot of basics research and clinical research on focused shockwaves, but still we don't understand fully how it works. There's still a lot of research to be done, and a lot of parameters to be examined. But what we need to know for each and individual device is the term, how much pressure can the machine produce? How much energy flux density can it produce? And that means millijoule per square millimeter, if you heard about that. And then again, how much energy is applied for each treatment. And that means in practical sessions, how many number of shocks do you give to be successful. The thing is that I worked with 5 or 6 devices during the years, and all devices need different treatment protocols. And this one here, with the 2 new devices I'm going to show you, is the fastest way to produce good results right now. So, we have to think in a spatial kind of way, that the shock waves are produced with this device here in 2 different ways. We have this cigar-shaped treatment zone here, which actually affects the tissues. I'm just going to skip this here. For other devices, this cigar shape alters in size. Some are very big, some of the competitors, some are very small. The thing is that the older machines had a very large cigar-shaped treatment zone, but the energy was scattered all over the place. So for each shock, the energy was here, the next it was here, the third it was here. So it differed very much when you used this therapy source too. And it caused a lot of pain on the skin and around the bone structures too, because of the scatter radiation. With this pizza wave too, the energy is so focused and dense in this cigar that it does not cause pain at the skin level or at the bone level. It only causes a reaction where you actually use this zone. So this is the animal that we're going to work with today. And the thing with this machine, that it can produce much more pressure, a higher pressure than its competitors. So it has more power, the pressure waves. And the treatment, the focused shock wave, is for much shorter duration than its competitors. And that means that when you use this device here, the patient will feel the treatment much more than Storz or Dornier. So, because it's so dense, the energy beam, you can actually start not only to change tissues, but you can also alter the pain that the patient has. Very, very fast if you use it properly. And the good thing with this device is that they have several headpieces. And what I can see they have here today is my favorite ones. These here is the F10G6. It's a double layer ceramic headpiece. That means that it has 2 layers of ceramic plates. So the energy beam is twice as powerful as the other devices. The same thing with this one here. It is also a double layered. So even though on paper it cannot produce as much power, the output is very, very strong when you use it on the patient. And all of you who work with shockwaves, you know that we use these gel pads to actually disperse the shockwave down into the tissues. So we can work superficial, just under the skin, and we can work up till 7 centimeters down the tissues with these devices here. And in my practice, we never need to go further or deeper than that, even with very large patients. The good thing with this device is that because it's double layered, you can actually go down in the body deep without losing very much energy. And if you want to treat things around the hip or the spine, it's very important that you have this device. It's the only device who can treat that effectively. So, just in very short recap, how do shockwaves work? What shockwaves do is that you actually put a mechanical pressure wave into the tissues, and that pressure is hitting the tissue and causing a biological response. And depending on how much energy you use, how many shocks you deliver, you can create different responses at the tissues. Cool. So what we see is that when we actually hit these tissues with shock waves, they become permeable. And that means that they actually start to open up the cell membranes, and a lot of chemical processes go on into the cells. And this is just a recap. We have production of pain-inhibiting enzymes. We have stimulation of microcirculation. We have neovascularization. We have modulation of pain, and so forth and so forth. So in general, what this means, just to be practical, is that the pain and regeneration are 2 aspects of this here. Sorry. So we cause regeneration of tissues, so sick tissues start healing up again. But the other very important aspect is that we also see a modulation of pain. We see a reduction of nerve fibers. We see a decrease in neurotransmitter transmission during this here. And we don't see it just only at the periphery, we also see it at the spinal cord level and higher cortical centers. You probably have many patients who've had pain for a long time, yeah? And what happens to patients when they have pain for a long time? All pain patients. They get sensitized by pain. So higher cortical levels, when they perceive pain for a long time, the pain is perceived higher and higher for the patient. And in the old days, the only thing we could do is give them more and more painkillers and more morphine and so forth, but that only accelerated the pain sensitization. So at the end, they had a lot of pain, even though they took a lot of painkillers. So how can we reverse that process? Is it possible at all? And it is with shockwaves. If you can deliver enough energy to these nerve fibers at the periphery, you can actually modulate the pain within 3 or 4 or 5 treatments. Even with a chronic patient who's been in pain for many years. So we actually see, first of all, what's causing pain in a chronic musculoskeletal problem. Does anybody know that? The main thing is, the reason why tissues don't heal up is that something is going wrong. The body does not know how to heal the tissues up. So it starts forming disorganized tissues filled with nerve fibers and invasive cells which actually produce a lot of pain-producing chemicals. And what guides this is the C nerve fibers and unmyelinated alpha nerve fibers who actually grow into tissues that need to heal up. And if they don't heal up, they don't retract again. They sit in there. And they're very painful when you press on them. And when you try and use the muscle or the tendon, it's painful too. Even in cartilage lesions, these nerves have to actually grow in to guide the immune system to repair the processes. If something goes wrong, they don't retract, and that's why it hurts. So you probably have patients who have osteoarthritis, but have no pain. It's a normal thing, we all get it. And then we have patients who have a little osteoarthritis, but have a lot of pain. What's the reason for that? Something goes wrong with the nervous distribution somehow at the periphery. And if the nerves down here keep on producing pain and don't heal up the tissues, they start stimulating the pain-producing modulating fibers of the spinal cord. And when they start for a long time, they go start in the brain and actually start modulating the pain too. And it goes straight down into the periphery once more. It's very complex and we don't exactly know how it works. But the negative impulses from the periphery are taking over. What the early studies showed is that if you give a high dosage of shock waves on tissues filled with these nerve fibers, which shouldn't be there, they die and retract. So you actually get rid of the pain. And I have many patients that I treat. And I always ultrasound scan my patients when they come in. I look at the tendon or the muscle or the ligament, and I see how it looks. And after 3 or 4 treatments, the pain is reduced by 50%. I scan them again. The tissues look exactly the same. And sometimes after half a year with rehab, the tissues look exactly the same, but they're pain-free and fully functional. So what am I treating? I'm not only treating regeneration, I'm also modulating the pain in some way. And I don't know exactly how. But I'm trying to find out a protocol that works to reduce this pain so I can get my patient back to health and start rehab so they can regain their normal activity. So you can all read these articles if you're interested, but I'm not so interested in the research. I read it all, but I'm more interested in getting my patients out of pain fast and getting them back to do what they like to do. So this is just to show you the pain pathways, how complicated they are. So I am an advocate for any treatment that you deliver to a patient. It has to be as effective as possible without causing any side effects. Would you agree with that? So, if you want to use some equipment or invest in it, you have to make sure that it works and the patient actually gets some results very fast compared to where else they can go. So when you apply this device, you have to apply the right amount of power, the right amount of treatment time, and the right number of treatments to get successful. If you're not precise enough, lack discipline, you'll fail. So you have to be focused when you do this. And that's why I always been ultrasound scanning my patients. I've been doing that for nearly 20 years now. I started out with a small device like this here. And it gives you an idea of what's going on in the body. First of all, it gives you an idea of what's going on in the tendon or muscle, or the synovium, or the meniscus, or the cartilage, so you know what area you have to treat. And when you've seen a lot of these patients, and you scanned a lot of them, you see a lot of alterations around the tissues. For example, when I started out, I merely treated chronic tendinopathies. That's where most of the research has been done. But when I scanned thousands and thousands of patients, I found out that it's not only the tendon that's sick, it's also the surrounding tissues. It's also, you never have a tendon by itself which is sick. You always see alterations in the surrounding tissues. So if you have a rotator cuff problem, you don't only have one tendon which is sick. You have 2, 3, or 4 tendons which are sick. You have synovium which is enlarged. You have inflammation. You have some cartilage problems. So you have all this together. So in the old days, I just treated one area and had some success. Now I treat the whole clinical entity, and I have very, very good results. So you have to think bigger than just a tendon or a lesion. You have to think about the clinical problem that they have. That's why we call it a shoulder impingement. What does that mean? It just means that we don't know what's going on, but it's just something is hurting under the shoulder. And we do a lot of tests and things and that. And in the old days, I thought, when I've done all my orthopedic tests, that's a supraspinatus tendon. I'm sure of it. Then I started scanning the patients, and no, there was nothing wrong with that. So it's not as easy as we think it is. It's much more complex. I can also scan patients in one shoulder and see some pathology, and then I just control by scanning the other shoulder, which doesn't cause pain. And I see exact the same changes there. So you cannot rely on an ultrasound scan alone, or an MRI scan, or an X-ray. The body is much more complicated than that. But when you bring all the different things together, then you get a better understanding of what's going on in there. And that's a very good thing when, if you're interested, that you can actually get a picture of what's going on in there. You can see it's not only one tendon. You also have some swelling in the bursa. You also have some enlargement of the synovial tissues. And then you can actually think, oh, I have to treat the whole area to get a good result. And that's what this device has actually helped us with this new linear device, that you can actually treat big area in a very short time to get a very, very good result. So, think of it. When we apply shock waves in these energy levels that I'm going to talk about today, you do not only create tissue repair in tendons, you do the same in bone tissue, you do the same in synovial tissue, you do the same in cartilage tissue, you do the same in muscle tissue. So every tissue that you hit with these energy levels, you create regeneration. The more vascularized the tissue is, the faster they respond. The less vascularized they are, the slower they respond. A tendon has very, very little vascularization. Very few blood vessels. And its turnover is therefore very slow. That's why a tendon heals up slower than other tissues. A muscle injury heals up very, very fast because it has a lot of blood supply. A bone tissue is actually the most vascularized tissue we have in the body. We don't think about that. That's why for stress fractures, pseudoarthritis, 2 treatments will fix it immediately after 6 weeks. Synovium, which is producing swelling in joints, is very vascularized too. So a few treatments which actually neutralize that. That's what we see in ultrasound scanning. We can see the synovial tissue. If you can actually reduce that by 80% within 2 weeks, you will decrease the swelling in the joints very, very fast. And the synovium is very heavily innervated by these nerves too. So they are one of the reasons why they have pain. It's not only the tendon or the muscle, it's all the surrounding tissues which are responding to them. So think about that. Cartilage has a very low turnover too, and not all cartilage has blood supply, but some cartilage has. Some of the very important ones, like the outer sides of the meniscus, are rich in blood supply. The labrum of the hip, the anterior hip, is rich in blood supply too. So you don't always have to operate these patients. You can actually treat them with focused shock waves instead. And the other thing is, we want to get these patients out of pain as fast as possible. That's my success rate. Why do patients come to us? Because they like you? They want to have a chat with you? No, they come to you because they have pain primarily, and because they lost some kind of function. So if you can actually show them within a few weeks that you can reduce their pain, they will gain confidence in you. And then you can guide them on and do rehab and what else they have to do afterwards. But you have to master that. Because most of these patients have tried medication and injectional therapy, and they are thinking about an operation. Is that necessary? No. For many of these musculoskeletal lesions, operation is not an alternative. We need something else. And that's where focused shock waves can help you. So what does all research show about shock waves when we have to put it into practice? And then we use randomized, controlled, double-blinded studies with a large patient cohort for shoulder injuries and things like that. And what do they show? And we have about 35 very, very large studies in the world of very good quality. And they show that focused shock waves, they work for these chronic conditions. They work better than injectional therapy. They work even better if you combine them with rehab. So rehabilitation and focused shock waves beats all kinds of treatment for these chronic musculoskeletal problems. But how should we treat them then? How much energy should we use? How many treatments do they need? How do we manage them? And when you look at all these studies, then a clear picture comes out. Can I get your recorder?
Okay. Is that when we use these shock waves here, at the energy levels that they can produce, it's very, very safe and does not cause any conflict. Better they respond. But there's also a limit to how high doses you can give them. Some animal studies have shown that if you give them 0.456
millijoules per square millimeter, it can actually cause tissue necrosis. There were very controlled studies on a rat hind limb or a leg of a horse, 6,000 shots at 0.5 millijoules just at the same spot, and they showed some necrosis right there. So, don't go above 0.4 millijoules. It's not necessary. With these new devices, it's plenty and you won't cause any harm. Don't go below 0.1 millijoule. It does not seem to have very much effect either. And then, 3 treatments is quite good. 6 is better. So most studies have been done on 3 treatments and 6 treatments. But the studies who actually treat the patient 6 times, those patients responded better. Again, if you use the device with a large focal zone and with a high energy density, you had a greater response. So if you have a focal zone of shockwave which is very little, you get a smaller response than compared to a very large focal zone. So how can we use that in daily practice? How can we use that? The way we can use that is that this device here produces a smaller focal zone, but very powerful. And this device here produces the largest focal zone in the world right now, but at a lesser energy. But when you use this in practice, this device will cause much more patient response, even at a lower energy doses, than the other headpiece will. And you will find that out when you try and switch between the devices and treat these patients. So I always start my treatment with the linear device, the first 3 treatments normally, and then most often the pain will have reduced, and the area which causes pain will have reduced too. Then I use this device afterwards to treat the rest of the areas for 3 times more, to get rid of the rest of the pain and get more regeneration into the tissues. So it's quite easy to treat with focused shockwaves. You don't have to have them stay over at night. You can have them in your clinic or your hospital department, and they can leave straight afterwards. The case history will tell you where the injury is. Your examination will show it too, orthopedic examination. But mostly palpation, pain upon active movement, and things like that will give you an indication of whereabouts the pain is or the problem is. If you're in doubt, always require radiology. If you think there's a fracture, X-ray. If you think there's an intra-articular problem, MRI scan them. If you think it's a larger complex area, ultrasound scan them. And if you can't do it yourself, refer and get the information before you start to treat them. So the more exact you are in your diagnosis, the better result you'll get. So I always urge people to do a real good proper examination in case history, feel, test, and make sure that you know what kind of area you have to treat. And often when we talk about the shoulder, even though you've done all your tests, and even though you have an MRI, it'll probably show you there's several things going on in there. So where do I start the treatment? What's causing the main problems? And that's where you can use this equipment again. You can use it diagnostically. Because if you can produce the patient's pain, then you're pretty sure you're on the right spot. If you produce some pain which the patient doesn't have, don't treat that. So it's a good thing talking to your patients and making them answer a lot of your questions, because then you're going to make sure that you're on the right spot where you have to treat them. And often if you treat the wrong place with this, just 5 millimeters away, 1 centimeter away, you won't get any good results. So you have to be sure you're on the right spot. Good. So just to reinforce again, what should we not treat? Don't treat any infections in the body, because focused shock waves will actually stimulate that process. So stay away from that. We don't want to go over cancer, tumors, stay away from that too. Even though several of my colleagues who are urologists and they treat the prostatitis, actually with cancer affliction, it doesn't cause any, they haven't seen any alterations of the cancer, only pain reduction, but we don't know. So stay away from it. Stay away from the brain. Don't treat the scalp or face. We don't know what it can cause the problems. Some of my colleagues said they could help on me if I get some treatment up there, but don't do that. Don't use it on very heavy clotting disorders. Patients on very heavy hemodiluting medicine. Make sure that they, if you give them a treatment, if they have a lot of bleeding under the skin, then discontinue the treatment. I never experienced it in my life so far here, not with the new devices. Pregnancy is a relative contraindication. If they have a stable pregnancy, if they have a normal pain tolerance, you can easily treat them. And again, stay away from large arteries and veins and large nerves. We don't know how it can affect if you have some plaque buildup in a vessel, so stay away from them. Large nerves, Patient will tell you if you put your shockwave over the sciatic nerve, they will jump off the table. Or if you put them around the nerve roots from the spine, they will also tell you that it's not very comfortable. You won't cause any harm as long as you move the probe away from the nerve. We can use it over small nerves, even the median nerve, ulnar nerve, and peripheral neuropathies. We can use it without causing any pain or any problems. Actually, they're doing research now on spinal cord lesions where they have severed their nerves, and focused shockwaves can also regenerate these nerves without causing any complications. So focused shockwaves on all tissues cause regeneration. So don't be afraid as long as you stay within these limits that I just told you right now here. The reason why we have many of these contraindications is that because the older machines, the electrohydraulic ones, had very much scatter shockwave, so it caused a lot of pain and you couldn't control them. With these new devices, it's a very controlled area that you actually treat. So we want to work in this area here, and I say between 0.1, 0.4 millijoules is the right area to treat. I'm just going to skip over this. So for all these lesions that we're going to go through today, for tendinopathies, muscle injuries, ligamentous lesions, cartilage lesions, labrum lesions, meniscal lesions, you want to stay within 0.1, 0.4 millijoule. With this device, you give about 2,000 to 3,000 shocks per treatment. Not more is necessary. And the frequency, you can use between 3 and 8. I always use 8. In my experience, the more energy you can deliver in a shorter time, the more you're going to shock the tissues so they start regenerating. And what we see is that the newest research shows the higher frequency we use with this energy level, the much stronger it is to pain modulate. So the reason is that when you put the shockwave on tissues which has an abnormal nerve supply, these nerves get irritated to start with, that's why it's causing pain, and the neurotransmitters are hammering away, and at some stage they run dry from neurotransmitter. There's simply not anything more. That's why the tissues go numb sometimes. The pain resides after you have given them a few minutes of shockwave therapy. After you do that 2 or 3 times, the nerve starts producing the normal activity of pain, neurotransmitter and substance P and so forth, so everything is getting modulated over time. So use a high frequency if your machine can do that. And the Pcl 2 is the only one that can produce these levels of energy at a frequency of 8 in a minute. So you're actually causing depolarization of the cell. And sodium and calcium channels in the cell, if you read up on that in your neurophysiology, actually can do that between 10 and 100 times per second. So if you only do it 3 times per second, the cells will adapt and the nervous system will adapt. If you do it 8 times a second, you're going to stimulate how the nerve actually responds in the body. And you'll get a faster pain modulation. So I treat these patients always 6 times. It gets me better long-term results. And I treat them most often twice a week for the first and the second week to pain modulate them. And then I go down to once a week. And after 3 to 4 weeks, I start them on rehabilitation with my colleagues. And then I ultrasound scan them 2 months afterwards and examine them again to see how their pain levels are, what their function is right now. If they are not satisfactory, I can give them 2 or 3 more treatments once a week, and then they continue with rehab until they're symptom-free. And with that protocol, I have a success rate over 90% for a total of our patients. That means that they are pain-free and fully functional after 6 months. So if you do this properly and with discipline and follow up with rehabilitation, you always have to do that, otherwise a lot of them will come back. The tissues have to be strengthened afterwards, and we know that with a tendon, it does not regain its strength within less than 6 months. Even though they're pain-free, it can relapse if you don't continue with the rehab. It's very, very important. Bone lesions only have to be plastered or held in place for 6 to 8 weeks. Muscular problems only 2 to 3 to 4 weeks. So the more vascularized the tissues are, the faster they respond. Wait, what was this? Yeah. So we know it works. So we have to apply a technique so it works all the time, and we have to treat the whole painful area. In my experience, I was too focused to start out with. I thought that I only had to treat one little point. No, you don't have to do that. You have to treat the whole clinical identity. Let's say the shoulder, you have to treat the whole area which is involved. The knee, look beyond the tendon, look to the synovium, look to the joint surfaces, look to the meniscus. When I see a chronic tendinopathy in the knee, I always see some changes in the meniscus, nearly always. Very, very early stages. Why shouldn't I treat that straight away to get some regeneration? If you wait too long, when the tissue is worn out, if there's no cartilage left, if the meniscus is totally torn, you cannot repair it. You have to take it while it's in its superior state. But then again, shockwave therapy does not stand alone. You have to think about what else can help this patient. So you have to treat the dysfunction around the joints where they have the problem. Look at joint mobility, look at the muscular problems. Start rehab as fast as possible. What else can I actually treat this patient with? Also, a good thing with the shockwave therapy is that you can actually evaluate the other structures. If I have a painful shoulder and I see a large fasciitis, I always refer or do an aspiration and a steroid injection so the pain subsides, and after 2 weeks you can start your therapy. Also, when you ultrasound scan, you can actually see the integrity of the tissues. You cannot always test how torn a tendon is. So if you see a large tear, 80% of the tendon, then you should probably instruct this patient to do some things else than you would tell another patient. And if you have a total destroyed and arthritic shoulder, this patient may not be your patient. It should be referred to the orthopedic surgeon. So you have to evaluate if it's something you can do something about, or if you have to refer to your colleagues. When we do shockwave therapy or rehabilitation, all the newest research says that you have to stay away from non-steroidal inflammatory drugs. All patients have tried that in the early stages, and they haven't worked for them. They work for a lot of patients in the early stages, but for the chronic ones, they tried them several times. But we know that tissues heal up much less well if you take non-steroidal and inflammatory drugs at the same time. So when they have to start a rehabilitation and focus shockwave, they have to get off these drugs. They can take paracetamol or other morphine products, but no non-steroidal inflammatory drugs. We tried with steroid injection, and it gives great short-term results, but long-term it does not give very good results for these chronic patients here. We tried all kinds of regimes, and it has some complications, so if you can avoid them, then don't. So I always advise that if my patients had had one steroid injection and no effect of it, then the injection was not made the right place, or the patient is not a candidate for injectional therapy. We always recommend, if you do a steroid injection or aspiration, always do it ultrasound guided so you know where you actually are sticking your needle in. PRP, do you use that a lot out here for these lesions? The research is very limited, and I haven't had any good results with it at all. And something tells me you don't want to stick in with your needle in a torn tendon and actually inject a large volume of liquid. I see a lot of side effects compared to good results with that. So you have to be very, very good at doing these things to actually to think about doing that. So what you have to look for is pain upon active movement and passive stretching. You have to train your palpation to be very specific. In some areas, it's nearly impossible to identify things. So that's where an ultrasound scanner is very good. So if you're on deep tissues around the hip, sometimes you cannot get to the tissues by palpating them. And most of the orthopedic tests are not very specific. So I always tell my colleagues or younger colleagues, if the patient has a pain on the front of the shoulder, the problem is nearly always there. If they have a pain at the back of the shoulder, they nearly always have a problem there. And the same thing is with the hip. Listen to where the problem is and do the orthopedic test that confirm that. And if in doubt, use radiology to actually tell you what the problem is. Sometimes if you have an intra-articular damage in the shoulder or in the hip, you have to refer, or you are suspect of that, you have to refer for an MRI before you actually go through there. Because sometimes it might be an orthopedic surgeon who has to do the treatment instead. So in doubt, refer. I also encourage you to measure your success. So write down the treatment status to start out with. What's the pain level? What's the functional deficit? And test it on the way so you can see how fast they respond and if your treatment protocol actually gives you some form of result. So what we have to work with in practice here is that we have to choose which headpiece do we want to use for this patient. What is the anatomy that we want to treat? How deep do we want to go down in their tissues? What kind of gel pad do we have to use? What's in our way? What should we stay away from? And then try and imagine how big is the anatomical area that we want to treat and correlate that to the focal treatment area of the device you have. I'll go into that just in detail before we go into the practical session. So because focus shock waves, they cause pain. And that's an elementary thing with focus shock waves if you want to pain modulate. Then the patient has to feel some form of pain. They have to feel a tolerable pain to get modulated. There's been done a lot of studies where we sedated people who received focus shock waves, and they did not get the same pain relief as the ones who didn't get sedated. So if it's possible, if you want to pain modulate, then don't use sedation. With stress fractures, pseudoarthrosis, it's very painful, and we don't want to eliminate the pain, we just want to make the fracture heal up, so there we always sedate them, because you don't want to work with the pain there. And then we plaster them afterwards until the fracture has healed up. Always, in my opinion, have the patient lying down, because it causes pain, then it causes discomfort, and sometimes the patients can actually become very dizzy or pass out, so have them lying down to avoid that. The other reason why I say that too is that when you work with these devices, and because they cause pain, the patient is going to move to start out with. And you work with this device on the patient's body in a very little area, so every time the patient moves, you're actually going to miss the spot that you want to treat. So have the patient lying down, tie him up. No, don't do that. Have him lying down, feel comfortable. Start out with a low energy level to get the patient's sensation so they can feel what's going on, and then increase it slowly for the patient. The other thing is when they're lying down, they are more stable, and you can actually, instead of holding this device, you can put it on top of the patient. So you just have to guide it, you don't have to lift it. So you have to look after yourself too, so you don't get any injuries. So I always have my patients lying down so I can just hold the device on top of them, and I don't have to lift it. And the thing with this double layer device, which is very, very powerful, and we use around the hip and spine, is that it's a little bit more heavy, but if you have the patient lying down, you won't feel the weight at all. And we also work with gel. For these shock waves to enter the body, it needs a liquid medium. And gel is slippery, yeah? So if you don't pay attention, you will go off the area they want to treat, and you will start actually causing some other pain. That's why I always advise you to skin mark the area that you want to treat, so you have a visual marker of where you have to be, or what the area has to be. Then you'll get success. When I observe clinicians who've been using that for a long time, the main reason why they don't have success is that they don't concentrate while they're actually doing their work. You have to deliver the right amount of energy, and you have to get some pain modulation before you move the probe on. If you slide forwards and backwards, you're actually not creating the right pain relief because you're stimulating other areas. So when I do like this, go and pinch you, it causes pain. If I do that again, I pinch you, it causes the same pain again. If I squeeze you all the time, you will adapt to the pain. That's pain physiology. And it's the same thing that you're doing with these focus shock waves. You stay in the same area, and you start, it hurts, and after a period of time, the pain gets modulated. And when you repeat that treatment 3, 4, 5, 6 times, you're going to decrease the pain significantly for the patient. The less pain they have, the better they start moving, the more proper they actually start loading their joints, and the faster you can get them back into rehab. So pain modulation is very, very important for these chronic patients. So, as I said, start with a low energy so the patient adapts to the pain, and increase it, and increase the frequency too. I always tell my patients that when we start treatment that we're not going to communicate in words, but in numbers. So they have to imagine the worst pain at a level of 10 and no pain at 0. And they have to tell me during the treatment how bad the pain is in numbers. So they start say 4, 4, 5, 5, 7, 7, and then I know I have to back off. Normally, in practical session, the numerical rating scale of 7 is where you stop. If it goes above that, you go down again. And if the pain subsides during the treatment and you're not on the right energy level, you can increase it again up to that level. But I'm just going to show you how practical you do it with this device here, because when you use the device for many years, you know how to use the settings better. And then you treat the target zones 2,000 to 3,000 with 3,000 shots. We tried all kind of protocols with 1,000 shots, with 5,000 shots, but it seems that all literature and all clinical experience is that's what works the best. You don't need more or less. As I said again, look for muscular problems, joint restrictions, stretch the tissues and so forth. You can also use the shockwave to actually treat these muscular problems if you want that at the same time. It's very fast, 2 or 3 treatments, trigger points, adhesions will be gone. Then I always stretch the tissues that you've been treating to regain some function. Have the patient sit up slowly, and you write down your treatment protocol, how many shots, what energy level you did at, and so you know that for the next treatment. And then you explain to the patient for how long they have to come to you, how many treatments they have, when they are allowed to start up moving again, and when they have to do rehab. You always have to wait about 3 to 4 weeks before you start heavy rehab on them. The tissues have to heal up before you start rehabbing. Otherwise, they have relapse. You can start with small isometric things and stretchings and things like that and proprioceptic work, but wait with heavy loading until there's been at least 3 to 4 weeks between the treatments here. So I always tell all my patients, don't do any movements that's provoking the known pain that you have. Not before I tell you to. So this is the device which we are talking about here. The cigar-shaped treatment zone is about 2 to 3 centimeters in diameter, and the length of the cigar is about 2 centimeters. So you have to think about that volume when you treat the tissues that you do. And when you want to treat with this device here, you have to stay in between 6 and 12 on the interval on this machine here. And this device can actually go 70 millimeters into tissues. We can actually hit them so far down. And because it's double layer, it does not lose its energy in the deep tissues. The physical parameters are so that the deeper we go into tissues, the more of the energy is going to be absorbed and scattered. So even though the machine says that you're on 0.3 millijoules, when you're 5 centimeters down the body, especially around dense anatomical structures like bones and ligaments, it will only be 1/10 of that. So when we walk around the hip and the spine, you actually have to go much further up in energy levels, which I'm going to show you too, because a lot of the energy will have dissipated when you go into the tissues. They simply scatter. So this is how it looks like. So you have to think about, because the beams are getting projected like this, nothing happens up here, no therapy happens here, and no therapy happens here. So I can put this headpiece on top of a nerve or vessel, but I put a gel pad on 30 millimeters, I will hit below that. I will not cause any damage to those structures. When I treat, let's say, the iliopsoas, iliacus, I can actually, with the right gel pad, I can put it on and treat the muscle only, where you can hit it manually or injectionally without causing any intestinal problems. We know from lithotripsy that if you use very high doses, 0.1, 0.2, 1.0, 2.0 millijoules per square millimeters, this is a dose that you actually use to disintegrate renal stones, calcification stones. You can cause organ damage. We use much less energy, and they've done a lot of studies on organs with that levels of energy. It does not seem to harm them in small doses, but stay away from these organs. Don't go close to internal organs, the heart, implants, pacemakers and things like that. Stay away from them. With this new linear device, it can go down to 3 centimeters, 30 millimeters. And it's the largest area, focal zone we have right now. And it's about 4 millimeters in width, and the broadness is nearly 5 centimeters, and it's about 2 centimeters in depth. So we can actually treat a very large area in a short time. And even though it only goes up to 0.16 millijoules, because we're actually treating a larger area, we get a much larger effect. The larger area you treat, the larger regenerative and pain modulation effects will you have. So you have to use numbers with caution, because many manufacturers claim that can produce so much energy, but it's only at one point of the beam that produces that energy. With this new double layer piezoelectric technology, the energy is evenly distributed in this focal zone, so you get a very large impact when you use it. So this is my first choice with all musculoskeletal problems nearly, within 3 centimeters in depth. So you have to think anatomically like this. This is a treatment zone. And what structures are linear in the body? Tendons, yeah? And ligaments. So if you want to treat a large tendon like the Achilles tendon, with a large focal zone, you will have to treat 20 different places to cover the whole anatomy. It'll take you half an hour and cost you a lot of time and money. But with this device, you can do the same by placing the probe in 2 positions on the Achilles tendon. You will not only treat the tendon, you will also treat all the surrounding structures, which I will show you, at the same time. And you'll do that in 5 minutes. That's faster than I could do an injection. So that's very, very fast. You can do that for one treatment. Depending on how you angle this device, you can actually choose what structures you want to treat. If you angle it transversely, you can treat a large area. If you have a large inflammation of a complex thing. If you want to treat a very linear product, you can treat them longitudinal. So this is me in my clinic on my day off. Came in just to show what I do. I ultrasound scan all my patients, and then I skin mark them, the area. So I examine them, I ultrasound scan them, I skin mark them. So I know with this device, it's actually a diameter of 2.5 millimeters. So I have to put it in a square of 1 centimeter and treat every little area for 300 to 500 shocks to cover the whole area that I want to treat. And because I skin mark it, I know I'm in the right spot. At the same time, I don't slide off. And it's very easy to slide off half a centimeter. So, especially after 7 hours at work. So, be sharp there. This is me scanning and skin marking my Achilles tendon. And I marked it here. It's a large area. Because I use this linear device, I can treat it in a very short time. Trigger points, I won't bore you with that. You can treat them exactly the same way just by putting the same device over that and get rid of them very fast with less effort from yourself. So, as my friend Charlie Brown says, and I can see on you, falling down, when you sit like you do right now, you start feeling depressed and have no energy. So the worst thing you can do is actually stand up and get some refreshments, and we'll just continue in 10 minutes, okay? Get something to drink and move around, and we're going to the practical work. Good. I hope you're refreshed, had something to eat, some sugar into your bodies. So we have just 1.5 hours left. So I would like just to go into the shoulder, just share with you my thoughts about how to treat this and how I do it. Then I would like to go into the hip or knee and just demonstrate that and talk about my thoughts about that. And hopefully we end at the ankle, the Achilles tendon and plantar fasciitis, so you can just see that too being treated. So, shoulder impingement, shoulder problems. The problems that we can treat in the shoulders are chronic tendinopathies, early stage osteoarthritis, early degenerative changes in the bursal walls, early cartilage lesions we can also treat, but they have to be in their early stage. As I told you, all tissues will regenerate with these energy levels here again. But if the tissues are too badly regenerated, if you have no cartilage, if you have a lot of osteophytes, no subacromial space, you have to refer them to the orthopedic surgeon to do their work instead. Otherwise you won't get any results there. So do your work properly, and if in doubt, refer to X-ray or MRI, so you know that you can actually help these patients. So most injuries are mentioned in the Supraspinatus Tendon. 90% of shoulder lesions are in the literature located to that tendon, but I've never seen a Supraspinatus tendon which was diseased without it having effect on the surroundings. That's why you have a lot of orthopedic tests which are not very specific. They all elicit pain with many of the chronic patients, so they're not very specific. Palpation-wise, you will find that a lot of areas in the shoulders are tender, and when you ultrasound scan them, you will see a lot of structures are affected. So always start from the acromion, go medially, go anteriorly, laterally, posterior, and palpate the areas to see what reproduces the patient's pain. And when you want to treat the patient, you have to treat the structures that reproduce the patient's pain. At my age, I have a lot of degeneration in my body. My tendons do not look like when I was 18 years old, a lot of places, and I'll have some early osteoarthritis here and there. That's normal. And when you actually treat them with shock waves, it will cause discomfort, but it's not the clinical problem that you want to treat. So you have to communicate with the patient and ask them, is that the pain you experience normally? If it's another pain, you're on the wrong spot. So I'm going to go through this here. Always have the patient lying down. When you treat the supraspinatus, you have to get the tendons out. You have to bring them as superficial as possible. Bring the arm back on the hand to the back. Lying down, then you will expose most of the supraspinatus tendon, also the infraspinatus tendon, and on the medial side, the biceps tendon. Oh. Right, here we go. If you want to go into the subscapularis tendon, lying down, outwardly rotate the arm, localize yourself from the bicipital groove, feel the biceps tendon. At the medial side, you have the subscapularis insertion. At the lateral side, you'll have the supraspinatus insertion. The infraspinatus you can treat back lying too, or side lying. When you have them side lying, you expose more of the tendon and you stretch it more, and it becomes a little bit more superficial. You will always find a lot of trigger points in these patients, and the trigger points have a tendency to come back in these patients until the ligaments and the swelling has gone in the shoulder. So concentrate about the deep tissues to start with, is my advice. Two muscles, though, you have to treat if they have a problem with the scapulohumeral rhythm, if they have protraction of the shoulder blade. you have to look at the subscapularis and the pectoralis minor. If they are very taut and filled with trigger points, you have to release them, otherwise it'll keep impinging. So your physiotherapist have to look at that problem while you're treating the other structures. All the new research shows that. So it's very hard to get to these trigger points who cause the spasm. So what we see around any chronically injured joint is that the muscle contracts to protect the joint. That's a neurological process that goes on. When they contract for a long time, they start creating trigger points. And trigger points are irritated, disorganized muscle tissue and chemical products. When they are present, they cause even more weakness and spasm of the muscle. So you have to get rid of these deep-seating ones. So if you diagnose them, especially at the subscapularis, which is very hard to get to, you can actually use your Shockwave device, the pinpoint focus one here, which lies down here, 2 or 3 millimeters gel pad, line it, have the patient lying like this, angle it into the axilla towards the shoulder blade, and you can actually limit all these trigger points immediately. And it will immediately create a slide back of the scapula and less swinging when you do that. The other point is the pectoralis minor. Due to the attachment on the coracoid process, it pulls the shoulder blade down too and causes protraction and limits the subacromial space. So if it's there, you can treat that too. And if you treat the pectoralis minor, which lies underneath the pectoralis major, it originates from the coracoid process and it serves to the 3rd to the 5th rib. You can actually treat that from lateral, having the patient lying like this again. So just underneath the coracoid process and angle your Shockwave beam in there, 2 or 3 millimeters gel pad, and you eliminate the trigger points there with 300 to 500 shocks. It's just a clinical aspect. A lot of other trigger points, I won't bore you with that. Oh, what's happened here? Okay. Just to show you how things look on an ultrasound scan, so you just get a picture of it. This is a healthy shoulder over here, and a sick shoulder here. This is your humeral head, and this is a humeral head too. This is the greater tuberosity. This is a cross-section, front of the shoulder here. Here you see the supraspinatus tendon. This small line up here is the supracromial bursa, and this tissue up here is the deltoid muscle. Here you see a sick chronic tendinopathy. The tendon is irregular, small black areas, hypoechoic areas, a lot of fluid in the supracromial bursa. The bursa wall are very hypoechoic and thickened. And look at the irregularity down here on the cortex on the humeral head, the cartilage on the humeral head. You see that with long-standing tendinopathy. You see actually formation of inflammatory small crystals in the tissues, and these small inflammatory crystals try to treat to heal up the tissues, but when present for too long, it causes adhesions to all the other tissues. And because the shoulder is actually one big area where the fluid can escape to, it's going to affect a lot of the other tissues and cause irritation and pain from the surrounding tissues. That's why we get a complex and a clinical finding when we treat these patients. If one tendon was only sick, we will get very specific clinical examinations, but we rarely find that on chronic patients. Do you find the same? So that made me think, after treating with focused shockwaves for many years, that I didn't get the results that I wanted to. So with the new high-end ultrasound scanners we have, we can see all these changes in the shoulder. And then I started treating all of the entities at the same time, and we got a total different clinical result. And it's not only me, it's also my colleagues all around the world who use the same technology. Down here, we see the tendon from the side. It's coming down from the shoulder here, attaching to the greater tuberosity. It looks nice. Here, it looks, again, a lot of fluid in the supracromial bursa. And the tendon down here is all blackened and irregular down here. So we see 90% or 95% of all tendinopathies at the attachment site at the joint surface. If it stays on for too long, it can rupture into tendinous, and sometimes it can rupture all the way through. They are more acute. There's been a lot of research going on by radiologists and clinicians in the latest years here talking about the rotator cuff interval. That's where the supraspinatus, biceps tendon, and subscapularis meet. And when you see diseases in one of these structures, this is the subscapularis, this is the biceps tendon seen from the cross-section, and here we see the subscapularis coming in. They are one unit anatomically. Here we have the coracohumeral ligament lying on top, and we have underneath the superior glenohumeral ligament, which has attachments to the capsule too. So if we get a long-standing disease process of these structures, it spreads to all of them. And it goes down into all the fluid escapable anatomical areas. Subdeltoid bursa, it goes down into the biceps tendon sheath too. And with these inflammatory crystals lying there for a long time, causes a lot of adhesions and irritation and inflammation, so you get a complex, painful shoulder. Just by treating one of these structures is not enough. You have to treat all of them to get them out of pain quickly and regain their movement. Here we see one of my patients. This is the acromion up here. This is the supraspinatus tendon coming down here. Here we see a typical tendinopathy. It's irregular black and white areas in here. The fiber structure is not uniform. A little bit of fluid in the subacromial bursa. And look at the cartilage on top of the humeral head. That's where the fibers have loosened, causing some irritation. That causes fluid coming out from the joint, from the glenohumeral joint, and spreading out into the bursae and down into the biceps longum tendon. This is another lesion that you often have heard about as soft calcification. Hydroxyapatite deposition disease is suddenly the formation of inflammatory crystals in the bursae or in the tendons, mainly in the shoulder. We can also see them in the hip sometimes. Causes acute pain. The reason why this is a soft calcification is that when we ultrasound scan them, and if I can see the cortex down here, it's a soft calcification, just like toothpaste. They respond very well to focused shock waves. 3 or 4 treatments, they are 50% less, and you can actually reduce their pain very fast with these patients. This is just after a treatment on that soft calcification. Immediately there will be a large vascular response. You will stimulate the vascular areas around it and speed up the regenerative and healing process very fast. So it happens within seconds after the treatment that you actually start up this therapy here. And when I put on the color Doppler, I only see the active capillaries which weren't present before. So you activate them immediately after the treatment at the right spot. So here I could measure on my ultrasound scan. This is 1 centimeter here, 0, 1, 2 centimeters. I had to use a gel pad, 1, 10 millimeters, 50 millimeters, just to target my area to treat there. The more specific you are, the better results you'll get, depending on what equipment you have. Because there's a shortcut to that. That's the back of the shoulder. This is the humeral head here. Here we have the labrum, posterior labrum down here. This is the infraspinatus tendon coming in here. It's very thickened, and here you can see how it pulls the cartilage up where it has its lesions. Fluid will come out here again, spread around. If you have a long-lasting lesion, you'll have inflammatory crystals going around the whole shoulder, causing degeneration and harm to all the structures in there. You want to end that as fast as possible. And that's where Shockwave not only pain modulates it to, but actually regenerates the tissues. This is the same patient. This is in front of the shoulder, down here. This is the biceps tendon. Look at all the fluid traveling down here. These small white areas is thickened synovium. They get attacked by these inflammatory crystals. They enlarge and produce even more liquid. Less space here. They get less and less movement, less and less power, and they degenerate even more. So one patient with one lesion, if they have it long enough in smaller anatomical spaces, it will spread. So you have to treat the whole area. Save yourself a lot of time, and do that if you possible can do that. Another thing is AC joint problems. We all get very early osteoarthritis there, just after the age of 30, we have small cartilage problems. This is the clavicle, this is the acromion, this is like synovial proliferation and some fluid, and look at the cartilage up here. It's very tender, causing inflammation when you use the arm too much. At that stage, it responds very, very well to focused shock waves. You can regenerate it totally after 3 to 6 months. You'll see normal cartilage there again, if you take it in that stage. So, now, I want a shoulder to demonstrate now. Half a year, it's good chronic. Chronic's more than 3 months, so he's a good candidate. And where's the pain sitting? The back of the shoulder? Scapula here?
And also the acid joint.
Okay, do you have any restriction of movement with your arm? Not really?
But when I contract and do elevation,
yeah.
I have a pain over here and some tightness over here.
Okay, I'm not sure this is the right candidate, but we'll just have a quick examination here. 3 seconds. So he had quite good movement, yeah? So I'm just going to take him up and test his passive movement and just relax your arm. Just pain there. Pain here. Yeah. Here.
Sorry.
Oh, sorry. Yep, that's fine. Any pain there? Whereabouts do you feel the pain? Okay. So I'm just gonna go. He has some general pain when I compress his joints, and we can do all these tests, the Breen's, Hawkins, Neer's test, and things like that. They make a quick scan. I go down and find the biceps tendon just underneath the acromion, and any pain when I press in here. Yep. It's always tender, so you have to press quite hard, you know. I go a little bit medial. Any pain here? No. I go a little bit lateral. Any pain out here? No. I go posterior to find the infraspinatus teres minor. Any pain in here? No. Any pain out here? No. Out there. I do this again, apprehension relocation test. It has to be really unstable for it to be positive. Any pain when I do like this?
No.
No. Any pain when I do like this? No. Okay. I go up on the AC joint. Any pain up here?
No.
He's not cooperating. I'm just going to come back here and press down here. Any pain here?
No.
Any pain here?
No.
No. He has a little bit of irritation in here. I don't think he has a large lesion at all. Otherwise he would pan out more than he does. So I'm just going to try and scan and see if we can find some tissues which are irritated in here. It doesn't seem to be coming from his spine here right now. When I just quickly examine him, it seems to be some small irritation in the shoulder causing some muscle spasm back here, but let's take it in an early stage. So if we want to... Oh, it's back there. Can you take off your shirt for me? So we just want to scan his shoulder. Put your arm like this. And we have it here, sorry. So I'll do a standing scanning. So we go in here. So what we see here, the bony structure here in the beginning of the picture. Oh, this here. This is humerus. This is the pectoralis tendon, and underneath that we have the biceps longum tendon coming up. So I'm trying to come up. Here we have the bicipital groove. Can you see this a little here? And here we have the biceps tendon. If we angle the probe wrongly, we get anisotropy, which says it all gets black. All tendons get black here again. So I try to follow that. Now you know what I'm looking for. So I follow it up. Here we have the tendon. And I follow all the way up here. And it looks present and quite healthy. I just scan it lengthwise. Here we have the tendon right there, all the way down. Sometimes I would see some liquid, some black areas around that. It doesn't seem to be influenced. I can go all the way up here. This is the humeral head you have down there. And then it goes into the glenoid labrum, where you can't find it anymore. It looks quite good there. So we have to localize the bicipital groove again, and I'm just going to come in here. What you see here is the subscapularis tendon. Whoops, the long one here. It attaches to the lesser tuberosity here. We look if we can see the fibers, no irregularities down here. It looks quite fine too. Not so bad. And then we have to find the supraspinatus tendon. So we have the arm sitting like this, arm backwards, straighten up as much as you can. Here we have the humeral head, and here we have the supraspinatus tendon. Whoops. Oh. Humeral head, supraspinatus tendon, bursa up here. I look if there's any blackened water or liquid in here, and I look medially. The structure looks quite okay. I go lateral. What we see here is the infraspinatus tendon blending with the supraspinatus. It's actually one tendon coming together here. I just scan it lengthwise. Here we have the supraspinatus tendon, and we have to find, here we can see there's a little break. This is the greater tuberosity where it attaches. I follow all the way down here because the fibers should stop here in anatomy books, but if you can you follow these fibers? They go all the way down here and actually attach a few centimeters down, further down. All tendons are not linear in structure all the way. When they get to the attachments, they fan out and create attachments. And here you'll often see overseen lesions, and the MRI scan can't show that. Only high sound ultrasound scan can. And you look at it all the way up. There's a little bit of liquid in here. Shouldn't be there. It shouldn't be visible. So there's some irritation in there, but there's no grade tear or anything in the tendon. So we go backwards, have the arm here. So we go to the infraspinatus tendon. Remember the pain was at the back of the shoulder, around the shoulder blade. So I hoped you had a lesion there. I couldn't elicit anything. But me not being able to do an orthopedic test which doesn't cause pain is not the end result here. We don't know that. So here we have the labrum. Here we have the posterior part. Oops. Infraspinatus tendon. What do we have here? Thickened tendon. We have a small lesion just here. This should be continuous with this part here. So we have a small tear at that tendon. Is it clinically relevant? He was a little bit tender when I palpated it. When I compressed it, he was a little bit tender. But this looked, in my arm, a little bit irregular and a little bit thickened. So I would, when I've done this here scan, I would go in and test this muscle to see if I can elicit any pain. Now I know I'm right on it here, at the middle of the probe, so I know exactly where to palpate. Take this thing away. And I go in here again. Any pain in here? So I'm really going all the way down through the deltoideus, and I'm pressing hard, and then I'm trying to press in here to see if I can feel any thickening of the tendon. There's a bit palpation in there. I'll try and muscle test it. So when you want to do a muscle test which confirms or can confirm or help you in confirming that it's an injury, you take the arm up to the position which causes pain. He had full movement, so I'm trying to stretch it as much as possible. So I want you to hold your hand there and resist me pressing in here. Any pain at all? A little bit?
This way.
This way? Okay. So when you have this little lesion here, it's what we call a posterior superior impingement. We have throwers, catchers, handball players, throwers, javelin throwers in athletes. because they take the arm so far back and accelerate it, they impinge the infraspinatus tendon underneath the acromion, and you get thickening and wear and tear there, and you get, when you release it fast, you can actually get some small lesions. That's why when we do this apprehension test, if you go in and press hard on the top of the humeral head and press backwards, it sometimes causes pain. Causes pain there? Yes. Yeah. We just say, maybe I'm just trying to be a policeman here, so we do the same over here. Same pain here. No. Maybe? It could be that, couldn't it? So we have a lot of different things which actually is concomitant with what's going on. So should we try and use the shockwave to see if that's causing the problem? It's a very early stage rotator cuff irritation here. So he hasn't got any of the other alterations here. Luckily, there's no damage or inflammation or fluid in the shoulder which have been able to cause any irritation to the other tissues. So this patient has come in a very good time. So I'd like you to lie down on your left side. I'll just clean up my mess here. Bad side up.
Facing this.
Yes, this side. Yeah, do the face this that way. Yeah, perfect. So you can see his face when it turns into pain, lying down here. By doing this here, like having side lying here, I just go inferior to the acromion, and you press up the humerus up through the deltoideus, so his tissues are quite superficial, and then you will have the attachment side out here. Any pain here? A little bit here. As you could probably see when you scan a long time, the tendon was thickened about 1 centimeter out. The infraspinatus is quite long and quite thick. It's about 33 millimeters in width where it attaches. So it's a long insertion on the lesser tuberosity, and the tendon's length is about 2.5 centimeters. And what I just saw when I measured him here, that was about 1.5 centimeters in length and about 2 centimeters in width. So that's quite a large area. We never see lesions in the teres minor. It's a very short and strong tendon. Very, very rarely. It's only by heavy accidents or falling accidents and things we see that. But then we often see ruptures of the whole posterior tendon part. So if I have an area like this, I have to put that in my head. That's quite a large area. So what should I do? How should I treat this patient fast? I'll use my shotgun, yeah? Because it's nearly 5 centimeters in width, so it encompasses the whole problem. It's 5 millimeters in the width here, and it's 2 centimeters in depth. So I will actually treat the tendon. I will treat the attachment sites on the humeral head. I will treat the surrounding tissues lying in the synovium. I couldn't see any big alterations there. But if you have impingement, you'll have impingement of the tendon towards the attachment site and towards the bursae and synovium on top. That's why we could see a little bit of fluid in the subacromial bursa too. So I want to treat all that in the same go. So using this device, we have to use gel. I'm putting it in here. And when I just looked at the patient, oh, there we go, I could see that the middle of the tendon was about 15 millimeters down. So I put on the 15 millimeter gel pad. Take it around my arm so I don't fall. And now I know the center of the beam of these two will be at 15 millimeters. And I will actually go 10 centimeters further down than that, and 10 millimeters on top of that. So I'll treat all the superficial and the deeper lying tissues too. So by using this, I don't have to use my ultrasound scanner. I just have to choose the right gel pad, and I can actually just treat the area, and I'm going to ask the patient if it produces the pain that he's used to having. Can I have a chair over here? Can I have a chair up there? As I told you, you have to watch after yourself so you don't get a bad back or bad shoulder or whatever. So I'm always sitting down, having the arm lying like this. Then I would, after palpating it, I would draw in the area which I have to treat with a skin marking pencil. I don't have that now. So I'm just going to go in here to demonstrate it. So I go from the muscular tendinous junction towards the insertional point. So I know I have a strategy. And I have to move this device 5 millimeters by the time. And as I told you, I deliver 300 to 500 shots per area. I hold it with both hands so it doesn't slip. So I know I'm the right spot, and I look at the area the whole time. So when the pain has subsided a little bit, or I have given the right dose, at least 300 shots, I move it on. And I give a total of 2,000 to 3,000 shocks. So with this young guy, I know from experience that I can start with this dose here. Oh. Have I got that out? So I start here, and I want you to tell me if you can feel anything. Is it resembling the pain that you had? Yeah. Any pain here? Any pain here? And any pain here?
No.
Okay. So I just search for the beginning of the pain. When I go into the muscles, there's nothing. Pain here?
Here.
Okay. So this is the first area. I hold this and I look at the numbers, and I give at least 300 shocks here. I have to treat about 1.5 centimeters to 2 centimeters. So I have to be quick at calculating how many shots do I give in total the first time. So I give about 300 shocks per area to cover the whole tendon for the first time. Is it okay? You tell me when it lowers in intensity, the pain? The same. You just tell me when it gets better. The pain is still the same.
Down.
Getting a bit down. I've given 300 shocks, so I move on 5 millimeters. Pain here again.
A little bit.
A little bit, okay. You tell me when it gets better. How bad is the pain from a scale from 0 to 10? 3. If it's too low, you can increase it. And now? 6, okay. Then you don't want to go higher?
No.
You stay here. 300 shocks. I move it on. Pain here?
Yep.
How bad is the pain? 6. Now we're giving him 0.1 millijoules per square millimeter. But you cannot rely on that number because you're actually focusing on a lot area structure. So you get a much bigger result even with a low energy. When I use this device and compare it to my other devices, which say 0.4 millijoules, the patient won't feel anything, but with 0.1 they will feel a lot with this here. So you cannot rely on the manufacturer's numbers. You have to go for the clinical results. 300, go again 5 millimeters. Now we go towards the attachment site. It always gets worse. The tissues are always more heavily innervated at the attachment sites than at the periphery. How bad is the pain? 7. We hold it here and just give it 300 shocks more. And I follow just the border of the acromion and just follow that. Then I know I get the whole attachment site. So, and I get a lot of other stuff too. So I'll get everything that might have been irritated. I move it again. Ooh, now we're close to the attachment site. Is that bearable?
Yes.
It is. He's probably not glad he volunteered now. No, it's just going to give it 300 shots, make sure. Is it decreasing or is it the same?
Yeah, it's decreasing.
It's decreasing. So we're not only regenerating the tissues, we're also pain modulating. You're not always able to actually get some pain decrease with the first treatment, and sometimes not with the second, and it'll first appear at the third treatment sometimes, in the bad cases. And we move it on again. Now we are at the end attachment site, and that's very, very tender. The thing with the infraspinatus tendon, it blends with the supraspinatus tendon, so you will always have an area which covers over. It'll never stop one end. And even though I scan with a high-end ultrasound scanner back home, I cannot see every little change, but when I use my Shockwave, it will detect if there's an injury there. Where does the pain go?
Down.
Down?
Up.
Up towards the shoulder blade and the neck. And I'm going to move it again. And here? No. Now we are past the attachment site. So we enter the supraspinatus tendon here. So my examination showed me a little bit, my palpation showed me a little bit more, my ultrasound scan showed me even more, but this one showed me actually what produced the patient's pain. And it fits with the pain pattern. When I move past the tendon, it doesn't cause pain anymore. So with all these parameters, that's where that Shockwave, this specific Shockwave therapy unit, is actually also a diagnostic unit. Because I thought so many times I knew exactly what it was, and it proved me wrong. And when something raises these questions every day for you, you start thinking, what's the disease process? Is it just one tendon? Is it more? And the good thing, if you were a more complicated patient, I would have started scanning at the front, the side, and the back, and I would see what would actually produce the patient's symptoms. So treat the major pain to start with. If something is remaining, treat the rest of the structures afterwards. Thank you very much for your help. Please sit up. I'll just have you sitting here. So I'm just going to try and do this here again for you. How does it feel right now? You'll have an immediate pain relief afterwards if you hit the right place and if you respond like this. We are lucky we got the patient without any major damages, but a tendon like this should be able to regenerate fully after 3 to 6 months. Please sit down. And probably you as clinicians, you know that when patients come in with shoulder pain, they often present with neck pain, shoulder blade pain, chest pain, arm pain. Where's the pain coming from? So you have to try and examine them very, very specific, and then you have to try and use this tool to help you to the diagnosis. Does it make sense? Any questions? No questions? Okay. We'll quickly move on to the lower limb. I would just like to demonstrate 2 more things which I think are clinically relevant and might help you in your daily activities. So, can you all hear me? Yeah? So the thing is that with my other devices, which are of older technology, my Storz and my Dornier, they produce more scatter, so I can't use them at the same way to diagnose my patients with. This here is much more specific because it's so dense and precisely. This device does not cause pain at the skin area or at bony contacts, so you don't get confused with other symptoms that you shouldn't be. I'll go. Okay. A quick thing about greater trochanteric pain syndrome. You read about that. There's a lot of misconception. There's been done a lot of research lately, especially from radiologists who try to find out what's actually going on in there. I was taught that it's mainly always bursitis around the hip which is causing the pain. Have you heard that too? Bursitis around the hip? It does not exist. It's a hoax. It doesn't exist. It's very, very rarely we see bursitis, and we see real bursitis after a hit, and you can actually see the swelling on top of the trochanter. But below the attachments of the tendons and so forth, we thought in the old days on MRI scans and ultrasound scans that these dark areas were liquid in the bursae. They are not. They're tendinopathies. It's dark fibers, thickened and irregular, grown together. So it's actually a degenerative process going on down there. And when we scan these patients now, we can actually see that it's not only one tendon. It's nearly always the gluteus minimus, medius, which goes in there and is causing a lot of irritation there. And we had a lot of synovium lying there, which are actually extensions from the hip joint. They communicate with the hip joint. So we thought that these bursae were the cause of the pain. They're not. We now know from exercise radiology that the iliotibial band, which comes down here, which lies on top of these tendons, cause friction and friction and friction, and then they start actually cause tendinopathy at the attachments at the trochanter, and then we have some fluid build up between these elements. So long-standing tendinopathy or pain around the hip is always involved with tendinopathy of these two muscles. We never see changes in the gluteus maximus muscle. It inserts on the posterior lateral femoral head, just behind the vastus lateralis and in front of the gluteus maximus, the adductor magnus, and it's very broad and very tense. So even the pain sits down there. It's actually coming from the iliotibial band, being compressed over the other enlarged tendons and causing some irritation of the synovium lying in between there. So if you want to treat that with the cortisone injections, and we did a lot, we got great results because all these synovial linings, they actually communicate with the hip, so it takes all away the pain for a short time, but they always come back nearly. And if you start exercising on it again, later on, it'll come back again. So you have to fix these tendon attachments down there. So by just treating one of them, it's no good. You have to treat the whole identity. So in the old days, I treated these small attachments here of the gluteus minimus on the anterior part of the greater trochanter and the gluteus medius on the lateral and posterior superior part of the trochanter, and I got some results, but they were not stable. Then I bought this device, and I put the patient side lying with the legs in bit flexion and adduction, so I actually brought the trochanter high up. It goes 3 centimeters down, so I could treat the iliotibial band, the synovial linings, the tendons, and their attachments on the trochanter. And you get a total different clinical results. You take everything away at the same time. And you have to take the whole lateral stability into consideration and not just think on one muscle. So you can palpate these areas, and when you palpate the trochanter in a long-standing problem, they'll be sore all around the place because it has spread around too. I will do that. And when you see that down there, you always see bony lesions at the attachments too. You see cartilage, cortex lesions where the tendons attach, and you have to treat them too, and you can do that too with this device. So this is the position you lie them in. You take this device, go from just on top of the trochanter, and you move it down in 5 millimeter intervals, and you have to go down over the trochanter at the distal attachments lying down there. If you do that, you'll have a total different success. All the other tendons you can treat there too with this device, but you already know that already. The Iliopsoas tendon is very often overseen. It's hard to get to and to palpate. You can do some muscle tests and things like that. But by using this device, the focal device here, you can actually just go beneath the inguinal ligament. You go medial and you palpate the femoral artery and vein. And when you go lateral to that, just lateral, underneath there, you will actually have the iliopsoas tendon going about 10 centimeters down and inserting on the lesser trochanter on the inside of the thigh. If you have the patient frog lying there, you just follow that line straight down. Use 20 to 40 millimeters gel pad. You will be underneath the vascular bundle, and the patient will tell you exactly when you're on that tendon. With all degenerative changes in the hip or tendinopathies, the iliopsoas will start react. It will try to offload the joint. And the iliopsoas tendon lies just in front of the joint capsule. And as I told you, we have so many synovial linings and small bursa coming out from the hip, and they communicate with all the muscles. It's not a closed joint as we thought in the old days. So we have small leap holes of inflammatory liquid which can go out there if you have some small osteoarthritis in the hip. And what we see when we ultrasound scan is this is from the trochanter from the lateral side. Here we see the gluteus medius attaching here. We see calcification in it. We see irregular trochanter. This is the iliotibial band being pressed up and causing friction in between here. So you get small fluid build up here. It's not a bursitis. It's a frictional syndrome. So you have to treat all this here if you want to be successful. Here we see a total avulsion of the gluteus minimus from the greater trochanter. And by the age of 60, 50% of the population will have a bald hip. Their gluteus medius and minimus will have ruptured due to degeneration. So can we treat these patients? We cannot get the tendon to grow back, but you can pain modulate them totally by treating the old insertional area. They'll get pain-free, and you can train them to use the other muscles actually to stabilize them. Sometimes on X-ray we see calcifications just lateral to the greater trochanter. This is a picture of the iliopsoas tendon coming down here. This is the femoral shaft, and the lesser trochanter here is very thick, and it's got filled with black areas, hypoechoic areas where the fibrous structure is missing. Down here, it's actually liquid from the synovial lining. It's not a bursitis. It's due to the friction of the iliopsoas tendon over the anterior joint of the hip. So you can inject in here as much as you want to. They'll have a great 2 to 4 weeks, but it will come back again if you don't actually treat this tendon here, so it actually retracts and becomes slim again. This is seen from a cross-sectional area of the hip. This is the iliopsoas tendon, very thickened. This is the femoral head and the pubic bone here. This is the psoas muscle and iliacus muscle here. A little bit of liquid underneath because it frictions against the joint. What we also see very much in clinic is patients who have pain when they flex their leg and internally rotate it or adduct it. That can be beginning of degenerative changes in the hip joint, small cartilage lesions and labrum lesions too. When we MRI scan them, we can look into the joint, and they have not enough osteoarthritis, so we will operate them, but they're heavily restricted due to the pain. This is one of these patients. This is the acetabulum up here. This here is the labrum filled with small calcification, pinpoint calcifications due to small lesions in the joint. This is the femoral head. Can you see it's a little bit irregular here and here? It's small cartilage lesions in the femoral head causing inflammation in the joint, causing pain, but you can easily rehabilitate them by actually limiting the pain and getting rid of the inflammation by giving them a shockwave here. You have those to use this device here to get far enough down, 4 to 5 centimeters, and you can hit all these structures without causing any harm. But it will reproduce their pain immediately, and after you have limited their pain, they can start actually lift their leg and internally rotate them, and you can start rehabilitation and actually regeneration of these tissues if you take it early enough. The same patient coming down here, femoral head. You see down here at the neck, the small attachments of the joint capsule here is also involved. So you have to treat this whole area here. You see we have 4 centimeters down here. So if you use a 4 centimeter gel pad, you will actually be in this area here. This is 2 centimeters. That's the width of this cigar here. So it's this big. So if you put it on a 3 centimeter gel pad, you will actually hit the whole area here without causing any damage to the femoral neurovascular bundle. So we see a lot of this early osteoarthritis in the hip where we can't do very much, but we also see a lot of early degenerative changes in the knee, meniscal lesions, and things like that. We did a very big Scandinavian research project with 8,000 knee patients who had beginning osteoarthritis, and we did some control groups who received surgical intervention, some who only received conventional rehabilitation, some who received medicational non-steroidal anti-inflammatory medication, and some who received cortisone injections. And it was done over 8 years. And it showed if you wait long enough, if you do 6 months of rehabilitation, it actually eliminated the pain with 70% of the patients, if you could do that quick enough. So the body has actually the ability in early osteoarthritis to heal itself and become pain-free to some degree if you get them early on. With more moderate to severe osteoarthritis, you have to replace the hip, of course. So when we go into these patients here, and not only look at the tendons here, sorry, I'm just going to show you here. This is a classical tendinopathy of the knee. Here we have the patella pole. This is a healthy patella tendon lying here. Down here we have Hoffa's fat pad. Right here we have a sick, thickened hypoechoic tendon here. Look at the fat pad down here. Can you see a difference? So when you palpate this patella tendon from A to P, does that cause a lot of pain often? A little? What happens if you pinch the tendon from side to side and underneath? Have you found clinically it hurts more? Have you done the same with the Achilles tendon? When you palpate them from P to A, it's a little bit tender, but if you squeeze them, it's much more tender? I never understood that. Why is it more painful underneath the tendon than where the lesion should be? We know that now, that these tendon lesions come from overexertion. Then we have an ingrowth from down here, from the vascular tissues down here, the fat pad, from nerves and vessels, these C nerve fibers, which should heal or guide the immune system to heal the tendon. They somehow fail because we don't offload them or age or whatever, and they stay in there and they give the wrong information, and we start the formation of irregular matrix and fibers lying mixed together each other. And these C fibers are still lying in here, in this tissue here, but they come from down here. So I started trying to put my Shockwave on here. Then I tried to put it down here. And you know what? It hurts much more down here than it does up here. So I thought, Jesus, maybe we're on the wrong spot. And then 5 years ago, FIFA, the big football club association in Europe, you know that? They hired 5 English surgeons to find out how they could actually get their top football players healthy with these chronic tendinopathies in their knees and in their Achilles tendon, because they were resistant to rehabilitation and they were out for half a year to a year, and it cost them many billions of euro. So these surgeons developed a new scanning technique, so they actually saw these vascular bundles coming from up here. So they thought, instead of operating here and try to scrape out the inflammation, has no success. So they did an injectional therapy, high volume injection, 50 milliliters of saline water, a bit of alcohol, a bit of corticosteroid, and they actually injected it down here at the peritendon. Look at the peritendon here and here. It's all white and thickened due to this ingrowth. So they injected all this high volume saline here and separated the tendon from the fat pad and severed all the blood vessels and C nerve fibers. They were very sore afterwards, but they had 90% success rate of getting them back after 3 months. And then suddenly the tendon started healing up properly because these C nerve fibers didn't interrupt the healing of the tendon. So in the old days, when I used Shockwave, I used it here. Got some results if it was up here. But now I treat the whole area here. 2 centimeters with this guy. So I treat the fat pad, I treat the vascular ingrowth, I treat the peritendon, I treat the tendon, and actually causes these fibers to retract again. So you get a total different pain relief from the patient. And you secure a proper rehabilitation of these tissues. So be smart. Use the shotgun. You don't even need to scan them. Just put them on and know your anatomy. This is just a tendon again. This is you can treat the Anserine bursitis and the runner's knee exactly the same way. Here we have a Anserine bursitis, tractus iliotibialis. It's like the runner's knee. It's coming down here, the tendon, to the lateral femoral condyle. We see a thickened tendon over here compared to here, and all irregular. We see built out of fluid. It's not a bursitis. It's synovial lining producing liquid due to the friction. So you have to treat the whole area here, not just the top. So use the linear device to start with. It'll make your job much easier and you have much more success. Another thing, what we see with a lot of these degenerative changes in the knees, orthotendinopathies, is beginning of arthritis of the knee. This is the femoral condyle. This is the tibial plateau. This structure in here is the meniscus. Here we have the medial collateral ligament. We see a lot of synovial proliferation here. We see liquid coming out from the joint. We see beginning of changes in the cartilage here. At this stage, it's totally reversible. There's no lesions in the meniscus still, but it causes pain. They have swelling, and they have all the clinical signs. If you treat them with focused shockwave, the pain production that you actually relieve is very, very significant with these patients. Now we only operate patients who have locked knees or can't stand on them at all and don't respond to this kind of therapy. Again, a lot of them will have swelling of the ligaments. They will have compensatory tendinopathies because they loaded their joint wrongly. So treat the whole area. Use the linear device and treat these lesions with great success. Again, injectional therapy here.
10 years more than.
Okay.
So keep playing football, basketball.
And where do you have the pain?
Here.
Yeah, just less. Okay. Here we have a patient who ruptured his PCL for some years ago and kept on playing football. What happens if you lose one of the ACL or PCL? The joint gets a little bit unstable, and you get some irritation of the joint surfaces. First thing that happens is some cartilage irritation, meniscus irritation, synovial hypertrophy, and so on. That's the perfect patient I would treat. I would treat him first with shockwave, and I would refer him to specialist rehab so we actually could gain some of the strength. If it's too unstable, he has to get to operated, but you rarely do that with a PCL. It doesn't cause enough problems. So, try and take off your shoe. And put up your knee here. So we have, just lie down for me, that's easier actually. So we have, again, 90% of all lesions of degenerative nature and of cartilage and meniscus lesions are sitting at the medial anterior horn of the meniscus due to the loading mechanism of the walking and running mechanisms. So we go in here and palpate the tendon. That's not so bad, is it? So we go into the joint surfaces. Any pain in here?
Not really.
No. I'm just going to check the integrity. Oh, can you see this? Yeah? That's a good PCL. ACL is intact. You can feel that, but you can see here. So I'm just going to test the knee a little bit more. Any pain when I do like this? No. Any pain when I do like this? No. Try and lie face down. With all orthopedic tests, you have to be quite evil to create a response, yeah? Meniscus compression test. Any pain here? Any pain there? Not really? Good, lie on your back. So luckily there's no great injury here. So I'll just try and scan his leg. No, there we go. So we'll just look at his joint surfaces here. So, can I use the pointer? The pointer? Here, oh yeah, this doesn't work here. Yeah. At the top of the picture here, you see the patella pole. Can you see that? That's up here. And this is the patella tendon. Do you have a pointer? Oh. This is the patella bone. This structure here is the patella tendon. Can you see the fibers? Down here you have Hoffa's fat pad. Follow the tendon down till the insertion on the tibial plateau. That's the tibial plateau here, where the tendon ends. We go up again. It looks quite nice there. Not too bad. So we go medially. So we want to try and see the meniscus and joint surfaces. Yeah. This here is the femoral condyle. This is the tibial plateau. This triangular structure is the meniscus, the anterior horn of the medial meniscus. We try and follow it around. Oops. Might not be visible for you, but suddenly we use the, you can nearly see it's quite regular here. Can we just get it a little? You need a trained eye. You need to have been doing this here for a long time. But here the meniscus looks quite nice. When I go up here, more medially, then I see the outer surfaces here, small calcifications in it. It doesn't look that regular. Can you see there's some shadowing here? Can you see this tissue here? This is coming up here. Is the medial collateral ligament. This structure here. It should be nearly lying down here. So we have a lot of fluid tissue and synovial proliferation right there. I'm just going to go a little bit further. And what we see here, can you see this structure here? Small holes in the cartilage here, in the cortex there. And with a lot overlying fluid here. So he has some beginning osteoarthritis right in here. And the thing is, we have most of the injuries, oh look here, you can see it's all irregular there. Most of the injuries are actually at the outer part of the meniscus, and it's only the outer third of the meniscus which is vascularized. If we have a large tear or injury at the inner 2/3, we cannot cause any regeneration there. If it keeps on causing problems, we have to refer to an orthopedic surgeon. But if we have an injury with not a communicating tear through into the middle, we can actually cause some regeneration and pain relief. So always start with that conservatively. So I know which area I'm going to be in. I couldn't really palpate it with my fingers because the injury is probably a bit further in. Again, apply this device here. And normally I use a gel pad 10 because then I'll have from the skin level up till 2 centimeters into the joint, I'll actually start regeneration. I saw some alterations already at his medial collateral ligament, at the tissues between the medial lateral ligament and the meniscus, at the meniscus and the bone surfaces here again. So with this device here, just by going from the top of the tibial attachment sites and taking it up 1 centimeter or so, I will actually treat all the structures here. Often we get a great pain relief after 2 or 3 treatments, even though no regeneration has taken part, but then they'll be able to actually activate the muscle and start rehabilitation here. So, just by palpation, I'll just check out that I got the right gel pad. I don't. So this was a 15 millimeter. I'm just going to take a 10. I'm just going to take some of the gel here. I think. So we're going to reuse the gel, environmentally friendly. That's it. Use a little bit of gel. Palpate the tibial plateau, and you actually have to go just underneath that because that's where you have all the fiber attachments. You couldn't see that with this scanner, but I can see that with my own back home. Then I go into the painful area. I turn down the energy. I'm quite kind to this guy here because at the bony attachments, you're very heavily innervated, so it's going to be quite painful. So I'm going to palpate. So I want you to, can you feel that?
Yeah.
Yeah. I hold it on here. So it's actually just underneath the tibia, but it's very, very painful. And it shouldn't be painful in a healthy patient. If I go down here, any pain here? No. I'm on the bone here, no pain there. I'm going to go up here again. Painful? Yeah. So you have to take your anatomy into consideration. So you start there at the attachment sites. That's actually a very painful area. And this area is painful, but it's not getting loaded. So why don't get rid of the pain? It's ridiculous, interfering with his normal movement of the joint. So I'm going to move it up 5 millimeters, and here, pain, up. So now we are at the lower meniscus and all the other tissues that we just saw. I give it 300 to 500 shots. And these patients, these beginning osteoarthritic changes in the hip and the knee, they respond the fastest with pain relief. They respond very, very, very fast because they are so hypersensitized in these tissues. I move it again, 5 millimeters. Pain here. Yeah. Now we're at the middle of the joint. Painful? Sorry. And now we're only at 0.023 millijoules. And it's causing a lot of effect because it's a double layer and it actually hits all the tissues at the same time. You're going to cause a violently pain modulating activity here. Get better, the same. Better. I move it up again. And now we are coming up to the top part of the meniscus and the femoral condyle where we saw some small cartilage lesions too. It's getting better? No? Not much. So I hold it here for at least 300 to 500 shots, and luckily I'll get some form of pain modulation. Next time I treat the patient, I would be able to use a higher energy level, and the pain will subside faster. And from time to time, the pain will subside much faster, and I can use higher energy levels. I'm going to go up here again. I'm up here, not so much. No, now we're at the femoral condyle higher up. So it's quite short area, but these patients respond very, very fast. We have a problem with his PCL. I don't know if you'll be able to rehabilitate him or if he has to have surgery. The problem with PCL surgery is that it's very limited in success rate. ACL surgery is much better, but still there is some form of relapse and complications. The younger the patient is, I would recommend it. The older the patient is, I wouldn't recommend it. When we put a graft in here, it'll only have 10% of the original tendon strength in there. So you still play football? So if you want to play football, I would probably get your PCL moved. I don't know, I know. But in my experience, I would. But you could try with this first. I would definitely give it a go. Get rid of all the pain impulses here and try to rehab him and see if that does the trick. If it does the trick, it's fantastic. But you can help him with the pain, at least. If he'll be able to really go back to football, we never know. Thank you. Yeah. Players which have multiple ankle distortions, both on the medial side and lateral side, And when we scan these patients, we see ligament thickening and irregularities, and they're very resistant to rehab. Bone here, there are two individual ones coming from the medial malleolus. So I'm going to try and find the talus down here. So I'm going to go just in front of the medial malleolus and press right in here in between while I evert the foot. Any pain here? A little bit down here to the okay. So now I'm actually going from the medial malleolus to the navicular bone, causes more pain. Then I'm going down to the calcaneal ligament here. Any pain here? Just a little bit, and I go back here again. So just by palpating and knowing your anatomy, you can actually elicit the pain that the patient has. If he has a ligament injury here, he has a capsular injury, and he'll probably have some avulsion problems at the medial malleolus and at the calcaneal, navicular too here. So we have to treat all that too. So just gonna check any pain when I do like this. Good stability. So it's a classical football ankle. Normally they sit on the outside, but you often have the medial ligaments injured, especially when they jump up to make to actually hit the ball with the head, and when they fall down again and get pushed, they get an inversion injury when they can't control it. That's where I often most see it here again. So we're gonna just scan the patient. So first of all, we want to see into the talocrural joint to see if there's a lot of effusion of fluid. If there's a lot of fluid in there, we just have to evaluate the joint surfaces. So here we go. This here is the tibia, and this here is the talus, talar head, talar dome down here. And you probably know a football ankle. That's why we have a lot of avulsion problems here at the front of the ankle here again and down at the talar dome. So I'm just going to see if the cortex here looks okay. Is there a lot of black fluid in here? No, not really. So there's no acute injury he has there. So I'm going to go down to his medial malleolus. That's the one you can see here. And then I'm going to try and find the ligaments. Here we have the talus. There's no darkness here. So we go down to the calcaneus here. And I would like you to do like this. So I stretch out the ligaments here. So now we go here. I have to be specific because it's a small structure. Here we got the medial malleolus here again. What we see here, this structure here, you have to be, it's actually a ligament. So I'm going to twist the ankle and see if it's intact. There we have it. It's intact, but you see up here, we see some blackness here. It shouldn't be there above the ligament and down here, and it's not uniform. It should be a straight structure. It's like a bit triangular, so it doesn't look homogeneous. It should be like a tendon. It should be the same width all the way down. When I go up here to the attachment site on the medial malleolus, I look, oops, I see some here. The cortex, I can't follow it. I can follow it again, but not here. Ligament is not very nice. So there is some pain when I palpate it and when he plays football. So it's not torn, it's intact, I can see that, but there's some scar tissue in it. And scar tissue and ligaments are very, very painful. Due to the anatomy down here, it's hard to use the linear device because I cannot get into the structures, and that structure is not more than 5 or 7 millimeters long. So it's quite small, so I can use the pinpoint focus instead. So I want to see if I create the same pain that I did with palpation by using this. So we're just going to take the other device in here. Why do we have that? Do we have the other headpiece? There we go. So this device is very, very powerful. So you have to watch out when you treat ligaments. So you have to use very low energy levels. They're very superficial, so you only use a 5mm gel. Pat, can I have the 5mm? So only 2 or 3 to start with. Make sure there's gel all over the place. If you have any air bubbles, you won't get the same energy level out there. So I'm going to find the ligament again here, painful in here. I'm just going to fall. So we're in the area right spot here. The patient will tell you when you're on the area. Yeah. So here we are straight at the bony attachment. And that's if these injuries don't respond to rehab, then you have to give them Shockwave. And they will pain modulate very, very, very fast. So I'm straight on the ligament here. And again, at the bony attachment sites, that's where you'll find most of the pain. That's why sometimes with a small lesion of a ligament, you will only see it when the patient actually does sports and stretches the ligament. Then there will be pain, not by normal walking. So I hold it here again, just for 300 to 500 shots. I follow it down here. Follow it down here. Okay, so I always recommend, so it's mainly at the attachment sites where you have the pain, but I treat the whole ligament anyway. And normally, the thing with ligaments, you can start very, very low, but the next time there will be much less pain, so you can increase the level of energy very much afterwards. Gonna go down here again. Now we actually...
3 to 500 times?
Sorry?
3 to 500 times or more?
3 to 500 times per spot, just like any other tendon, anything else. It's the same thing, so you want to do the same. So you only have to hold this device 3 places on the tendon because it's not longer. Now we're down at the other attachment site. So you can give it 500 shocks per spot. But you have to be right on the spot, otherwise there won't be any pain. This is 3, it's only 0.24, sorry, it's 0.12 millijoules. It's very low to start with. Still the same? Okay. And down here. So now we're at the attachment side here. So often when you're done rehab, these patients will be able to do everything on the balance board, and they can do all kinds of exercises, but it only hurts when they do football or run. So the only way you're going to get the rest of the symptoms away, because you cannot do anything very much more with rehab, is to use the Shockwave therapy device. And these patients, they respond very fast. 3 or 4 treatments, they're much better, because it's not torn the ligament. It's mainly just hypersensitivity in the ligament due to the irregular structure. It's intact. So one of your colleagues asked, do we only use this with chronic cases? What about acute cases? Can we use it there too? And there's no right or wrong, but when you have an acute injury, you have full vascular response, so the body tries to heal up itself. I would rather recommend that you get supportive care by the physiotherapist, ice therapy, taping, bandaging, isometric exercises and things like that. But if you have recurrent injuries to the same ligament or tendon, then it's a good idea to give it straight away, because there's something wrong with the structure and you want to cause some regeneration. And again, Shockwave can pain modulate too. And do you really want that with an acute patient? You don't want him running around too much, do you? The pain is actually guiding him not to re-injure himself. So sometimes you have to think, what kind of patient do I have? Is an elite sportsman who's going to run straight away when out of the office when they feel better, then they're just going to re-injure themselves. So in general, recurrent injuries, I would recommend it. Acute injuries, you manage physiotherapy. Any questions? Any questions at all? So you're experts already. Yeah. Thank you very much. So, thank you. I'm not a very clever man. I'm just curious. And when you see lesions, think around the lesions. And if you have one injury around the joint, it'll start compensating, and you'll get a lot of other injuries. And if you treat these kind of early degenerative changes, especially around the hip and knee, and also the ankle, you will actually get amazing results which you didn't get before. And if you have a device like this, you don't need to ultrasound scan. You have to palpate and examine, and then you can use it straight away, and just by the patient's response, you can actually treat this patient in a very short period of time. So with this patient, I would use this device 3 times, and then he would say, oh, it only hurts there. Then I would use the other device and try and get the rest of the pain out there and cause more regeneration of the tissues. So you can see by using a high frequency energy level that does not cause any complications, you can't do anything wrong. So it's quite easy, isn't it? I know it's late and I've been trying you all day here again. Do you have any questions to all this here?
I got a question.
Yes?
One of the slides you have is gluteus medius.
Yes.
And then one of the picture is the tendon is get partial tear.
Yes.
So is there any chance if I use the Shockwave working on a partial tear tendon that will cause even more tear?
Good question. If you have a partial tear of a tendon, if you use Shockwave, can you cause more tear? There's been 2 studies have been done on the Achilles tendon, where they had large partial tears, 70-80%, and they gave them 3 treatments of Shockwave. The patient felt better, and it ruptured afterwards. We have the same studies with cortisone injection, and the authors of these investigations don't think that it is the cortisone or the focused Shockwave. It's because the patient gets rid of pain, and then they think they can run again and do things. They weren't exercise restricted. So these patients, when they took them out, they had started doing exercise with a tendon which had not healed up. So when you use these doses here, you cannot cause any damage, more damage to a tendon, as long as you stay below 0.4 millijoules with this device. You'll not be able to cause any damage. What you have to do is, if you're suspect of a large tear, start the treatment, but you have to immobilize them. You have to tape them for the first 3 to 4 weeks until you scan them again and you see some integrity of the tendon. Then they can start doing exercise, but you will often find that the pain goes away fast, and then they think they can run on the tendon again, but it's not strong enough, and then it's actually going to rupture. So the treatment itself cannot cause any harm. But you have to manage your patients. As I told you, don't have them do anything that actually causes their pain for the first 3 to 4 weeks. It takes that long time. I've been scanning for so many years, and after a month I scan them again, just to see if the weight-bearing tendons like the Patella tendon and Achilles tendon is getting a better integrity. Then we know we can start them and have a more heavy exercise. But you have to go through some form of rehabilitation where you test the strength of the tendon before they return to sport. Makes sense, yeah? So as I told you before, focused shock waves with chronic conditions does not stand alone. They have to be rehabilitated by a good physiotherapist if you want long-lasting results. And especially with elite athletes, which I see a lot of, handball players, football players, soccer players and things like that, runners, you have to tell them exactly what they have to do. Otherwise, you won't take responsibility for your treatment. Any other questions? You know everything about focus shockwave now. Yes?
How is your experience with, for shockwave treatment with trigger finger and snapping hip?
Yeah. Snapping hip, if it's external or internal snapping hip. Trigger finger, let me answer that too. I treat that with great success. If they have a trigger finger and they can elicit the trigger finger, you get very good result with focus shockwave. It takes a little bit longer time, but instead of going in injectionally and actually cutting the pulley A1, it's better because you get more stability in the finger afterwards. So I would always try out with focus shockwaves to start with. With internal and external snapping hip, there's a biomechanical aspect which you have to take into consideration. You have to see if there's any hip pathology, cam or pincer configuration, if it's a deep lying hip, if there's any intra-articular cause of an internal or external snapping hip. The internal snapping hip is the Iliopsoas tendon, which actually runs around the muscle and goes down again when you flex and externally rotate the hip. If it's just due to a normal tendinopathy, you will treat the Iliopsoas tendon as I showed you, and you will get good results. External snapping hip is the iliotibial band, where it attaches over here and runs into the tensor fascia lata and gluteus maximus. It's too tight, so it snaps over the hip. You have to look into, is there any hip malposition? Is it due to tendinopathy, thickened tissues underneath? Or is it just due to a tight gluteus maximus? If it's a tight gluteus maximus, it's a rehab thing. If it's due to tendinopathy, thickened tissues underneath, under the iliotibial band, you can treat that with focus shockwaves too. But you have to do the right diagnosis there. Always rule out intra-articular damage. I've had so many of coxa profunda where the hip has been misaligned. I've had many pincer hips where it has caused the problem. I have had many cam configurations, cortical buildup on the femoral neck, which have caused the problem. So you have to rule them out first with x-rays. It's causing a thorough examination before you make that decision. But in general, you can treat all musculoskeletal conditions, but you have to look into what caused the problem. Is it only an exertion, or is it a skeletal abnormality or whatever? Because then it will just return again. So always take that into consideration too. And again, I have many patients where I can see the meniscus is 50% gone, with valgus of various stress of the knees for many years, and they have pain, they've been offered operation. I give them 6 treatments and they're 70-80% pain-free. And then they start rehab and they continue with the exercises and they have a fully functional knee. In my aspect is that you cannot replace human tissue with any other tissue without you're going to cause some complications. So if you can actually keep and live with the tissues that you have, it's better than getting a replacement operation. We have new clinical guidelines in Denmark for surgery, knee surgery, and as I told you, we have 70% decrease in operation of the knees. They do well with rehab if they follow a regime, and a little bit of menisc is better than no, because otherwise you get accelerated osteoarthritis, or if you get an implant, there's a lot of complications with that too, especially the knee. The hip is better. It's much better to give an implant there. So as I told you before, consider the alternatives before you start. I have many patients coming into me which have so severe osteoarthritis and are so restricted when I examine them, I refer them immediately to the orthopedic surgeon. I don't even bother with rehab because I can feel on this joint it's never going to regenerate. So examine your patients thoroughly. If you're in doubt, refer for radiology or refer to your orthopedic surgeon or rheumatologist to help you with the diagnosis. You should be a team. That's the way it works best for the patient, at least.
Excuse me.
Yes.
One question about the trigger finger.
Trigger finger.
Yeah. So we do any treatment, shockwave of the wrist?
Yes.
Yeah. Instead of just the finger.
When we do the trigger finger, you can actually see it's nearly always underneath the pulley A1. We have the flexor tendon where we see a thickening of the flexor tendon. So it's thickened above here. So we put it down, it locks underneath the A1 pulley, and when you try to lift it up again, it runs under this tendon here again. It's just a tendinopathy. It's just a thickening of the tendon. It's as simple as any other tendinopathy. And the smaller the tendon is, and tendons with tendon sheaths, which actually have a lot of synovial lining, they have much better response to shockwave therapy than the large tendons. So the Achilles tendon and the Patella tendon take longer time to heal up, more rehab because they're load bearing. The trigger fingers here, I think, yeah, I have over 90% percentage. But you have to, it's gonna take 3 to 6 months for them to retrain it. But the alternative is injectional therapy, or actually go in and cut the A1 pulley. If you cut that, you get instability of the finger. So if you can do something without cutting them up, patients, try and do that first. If it's an indication. And I put the linear device, put it on here with a 5mm gel pad. So I treat proximal and distal to the A1 pulley. So I do not only treat the tendon, I treat the pulley and the tendon sheath too. And you can actually see I have a high-end scanner, a Logic E9. It's a big machine, like a tank, standing in my office. And you can actually see the pulley and the attachments. And if you have a long-standing trigger finger, you will see the attachment sites on the side of the phalanx. They actually also thicken and compress the tendon. So the tendon will actually also cause some form of tendinopathy of the ligaments. And what's the difference between a ligament and a tendon? Anatomically, there's none. It's the same. One of them is just attached to a muscle and bone, and the other one is just from bone to bone. So they respond just as well. And when we talk about ligaments around the ankle instability, if they twisted the ankle for a long time and you see a thickened, painful ankle which keeps on coming back, give them shockwave down there and they respond just as well as a tendon. You have to give them rehab afterwards. And again, ligaments around the shoulder, around the ankle, are just reinforcements of the joint capsule. So if you have a ligament injury, you have a joint capsule ligament injury too. Then you have a capsule ligament and you have synovial lying in there, producing a lot of pain and swelling. So you have to go in and use a deep instrument, my friend there, 20 centimeters. You treat the bony attachments, you treat the ligament, you treat the capsule, you treat the interarticular structures which are actually irritated. If you just treat the tendon with a small device, you won't get the same clinical result. So sometimes, if I'm in doubt, you can give a diagnostic ultrasound guided injection and see if that takes all the pain, then I have to treat in the joint too. So it's more complex with joints, especially ankle, knee, hip, shoulder. They are interactive and you have to treat all the structures there. Not just as our young friend here who had a localized lesion that's easy to treat and help him with, but many of the other chronic ones you have to take everything into consideration. And if in doubt, choose this device here, because then you're going to hit all the structures anyway. Yes?
According to your suggestion, we should avoid organ, right?
Yes.
Yeah, but how about the intercostal muscle pain?
Oh yeah.
Very near the lung and
Yeah.
if it is not pneumothorax.
I would say intercostal pain, I would probably stay away from that, yeah? We treat a lot of rib fractures just with a 5mm gel pad with the pinpoint focused ones. You have to go 3 centimeters down as you get into the pleura of the lung. So if you just use a very shallow gel pad, you can actually cause healing up of these fractures very, very fast. But intercostal muscles, you're too close to the lung cavity. And always, when you use Shockwave, if in doubt, don't. Don't. Always, the patient's well-being is at first interest, yeah? I know it's been a long evening, but I hope that with some of my ideas I could inspire you a little bit to go further on with your diagnostic work and treatment work. And I would like to thank you all for your attention. You've been working well today. Thank you.